Hi there, my name is Nazul and I'll be presenting pancreatitis. And so what we're going to be looking at is the etiology, the clinical manifestations, the pathophysiology, diagnostics, and collaborative care that is involved in pancreatitis. But before we get into pancreatitis, as you can tell by the word itis, inflammation of the pancreas, we're first going to look at the normal anatomy and physiology of the pancreas and look at key cells that are in the pancreas or that makes up the pancreas. Some of the key cells are the alpha cells, and they make glucagon. And what glucagon does is it helps to break down glycogen stores in the liver to help with the release of glucose in cases where you're hypoglycemic. The other cell that's present in the pancreas are the beta cells, and they actually do the opposite. They help to release insulin in the times when your blood glucose level is high or you're having hyperglycemia. And what they do is facilitate the transport of glucose into cells to make you break them down, to facilitate or what we call metabolism, to make ATP, carbon dioxide, and water as waste. You could also store those excess glucose in times when you don't require to make all that excess ATP. Another cell that's present in the pancreas is the delta cells, and that really helps in digestion, and it releases something called somatostatin. The pancreatic duct links or enters into the duodenum, or the first part of the small intestine, by attaching or connecting through to the common bile duct. And the role of the pancreas really is it is an accessory organ to the digestive system, and it helps with the chemical digestion, or it facilitates chemical digestion. So as you can remember, the pancreas would secrete a bunch of enzymes, so things like lipase, amylase, trypsin, all of which will help in chemical digestion of the major food groups, such as fats, carbohydrates, and proteins. So amylase will help with the breakdown of carbohydrates, trypsin will help with the breakdown of proteins, lipase will help with the breakdown of fats. Also the pancreas, as you can imagine, the chyme or the processed food that's coming from the stomach is highly acidic because it has hydrochloric acid. One of the other things that the pancreas help with, it produces bicarbonate. And so if you can remember again, when you think about your acid and your bases, bicarbonate is a base. So if I want to neutralize hydrochloric acid that's coming from the stomach, then you add that base. So always, if you think back, the first part of the intestine, which is the duodenum, the pH usually changes from an acid pH to a basic pH. And the reason why is because these pancreatic juices that are coming from the pancreas into the duodenum has now a mix of bicarbonate ions that would help to neutralize the stomach acid. On the diagram that you're looking at, one of the things that you're seeing here, this is the pancreatic duct. And so stuff is going to flow into the duodenum, and as you could see, it's mixing with bile. And so bile also will go into duodenum and enters into the small intestine to help with the breakdown or the chemical digestion of your food. So when we look at the causes or the etiology of acute pancreatitis, there are numerous things actually that can result in acute pancreatitis. And there is an acronym that we use, or we can use, it's called GET SMASHED. And so what Get Smashed is, it gives you all the list of potential etiological reasons or risk factors for pancreatitis. So gallstones, ETO8 stands for alcohol, so chronic alcohol abuse, trauma, use of steroids, MUMS, autoimmune diseases, where usually the etiology could be idiopathic, scorpions or toxins, increase in your triglyceride levels, ERCP, drugs such as Lasix, thiazide diuretics, etc. can also. The reason why there are asterisks next to the gallstones and the ETOH abuse or the alcohol abuse those are the most common reasons why patients are exposed to or subjected to pancreatitis. Of the two, gallstone trumps it. So often patients with gallstones are more likely to develop pancreatitis more so than even patients with alcohol abuse, because you will find there are patients that could be using, or should I say, abusing alcohol for an extensive period of time and would have never experienced an episode of pancreatitis. So it's less common to see pancreatitis with ETOH abuse than it is. So gallstone is the most common, and that's why there are more asterisks next to gallstones. Just looking at pancreatitis secondary to gallstone, this was something that we looked at, or we spoke of once we talked about the complication associated with an obstructing gallstone, or complication secondary to choledocholithiasis, which is an obstructing gallstone. And in my lecture there, we spoke of this little opening, or this little sphincter right here, that is referred to as the sphincter of Oddi. And we said if ever there is an obstruction by a gallstone at the sphincter of Oddi, the patient would be at risk for pancreatitis. The reason why this is occurring is if you look right here, this is where if you have an obstructing gallstone at that point, now what you're looking at, there's two ducts right here. That's the common bile duct. And that common bile duct is then going to meet the pancreatic duct. And it will make sense in a minute, because there are certain things that are coming through this pancreatic duct that once it mixes with the bile from the common bile duct and it gets into the duodenum, that's going to activate certain enzymes or certain pancreatic enzymes that once, if there is an obstructing gallstone, as you're seeing right here, those pancreatic enzymes would have now been activated. And so what they start to do is they're going to back up into the pancreas, and or they're going to start to back up into the common bile duct, resulting in what we call acute pancreatitis. It will make a bit more sense once we go through the pathophysiology of pancreatitis, but I just want to show you from the perspective of when you do have an obstructing gallstone such as choledocholithiasis, it can result in pancreatitis simply because the pancreatic juices that are coming in will now be activated once it mixes with bile, and then once it starts backing up into the pancreas, it's then going to cause an inflammatory response in the pancreas. So now looking at the pathophysiology of an acute pancreatitis, one of the most common pathogenic mechanisms that is involved in pancreatitis is something called autodigestion. Self-eating, self-digesting of the pancreas. And we're using the word self-digesting or autodigestion because it's the own pancreatic juices with the particular enzymes that are released from the pancreas is what's actually triggering or precipitating the damage or the inflammation to the pancreas. We looked at gallstones in the previous slide, and so we said with a gallstone, once it gets lodged in the common bile duct and then moves and it gets lodged into the pancreatic duct or even at the sphincter of Oddi, what is now going to happen, the enzymes that were secreted by the pancreas in order to help with chemical digestion of food, so remember those enzymes are amylase, lipase, trypsin, they're going to get blocked, and so they cannot get delivered into the duodenum, but instead they're going to back up into the pancreas, and they're going to start, some of them will back up into the common bile duct. By backing up into the pancreas now, what they're doing is they're going to auto-digest or self-eat the pancreas. And that's where you're seeing here in this little diagram, which I have to give acknowledgement to have retrieved it off of Google. I find it a very helpful picture that's showing you the acute pancreatitis. So what you're seeing is enzymes. Once the enzymes are made by the pancreas, and as they're trying to make their way through the pancreatic duct and they hit an obstruction right here, remember what I said before, those enzymes are often inactive. Now, one way to look at the inactive enzyme, let me give you an example. For example, trypsin. Trypsin is actually trypsinogen. So when we look at the word, it's trypsinogen. Anything ogen means that it is inactive. So this is how this will exist in the pancreas as trypsinogen. Now, once it becomes activated and it gets under certain conditions, so it's going to expose to the pH within the duodenum and or it's going to mix with those bile coming from the gallbladder, that now becomes activated and the active form is referred to as trypsin. Once it becomes active and it becomes trypsin, that's what's now going to autodigest. So remember, once that enzyme is released from the pancreas, it mixes with bile. And so we're going to say right about here, where you're having your pancreatic juice that I'm circling in red, you now start to have activated pancreatic enzymes, your amylase, your trypsin, your lipase. And once it's blocked by a gallstone, for example, that has nowhere to go, and so it's going to start to back up into the pancreas. My next slide kind of sort of go into that, where it talks about trypsinogen, but I always want to highlight this word right here. So once we talk about the activation of the trypsinogen into trypsin, what it's going to do is start to autodigest or self-eat the pancreas. Looking at trypsinogen, like I said, it's in its inactive form, and once it's produced by the pancreas, it stays as trypsinogen, but once it gets released into the duodenum and it gets subjected into that basic pH, then it's going to convert into the trypsin, which is now the activated form, okay? In pancreatitis, that activated trypsin is going to start to autodigest the pancreas, and so what's going to start to happen is you're going to have spasm or reflex in the sphincter of Oddi. Please note that trypsin can also tend to activate other proteolytic enzymes that are present, and things like elastase or phospholipase A is going to be activated. As you can tell from the word elastase, this is an enzyme that will help to break down elastic fibers, okay? So what these are going to do now, they're going to start to eat away at the elastic fibers of blood vessels, and so they're going to cause significant amount of bleeding. So I want you to start to think perspective-wise now. If my patient is suffering from pancreatitis, what are some of the things that can happen, or what are some of the clinical manifestations or complications that they can develop? So if you think about pancreatitis and you think about your delta cells making insulin or the islet of Langerhans cell, if your pancreas becomes inflamed or your patient having pancreatitis, that islet cells become inflamed, they're not able to produce the right amount of insulin, so your patient then will go into hyperglycemia. And if their hyperglycemia is extensive, then I want you to think back to when we covered the diabetes and the complications. So one of the things that you can expect them to go into is DKA, or diabetic ketoacidosis. Phospholipase A will cause necrosis of the fats. So you're looking actually, when a patient goes into pancreatitis, a very, very ill patient with lots of complications that are now secondary to their pancreatitis that they're experiencing. So they can hemorrhage, which is then going to put them potentially into hypovolemic shock. They can go into DKA from the inflammation and the malfunction of their islet cells, or the islet of Langerhans cells, and so they cannot make insulin. And you're also going to have some fat necrosis that is occurring now in these patients. So we mentioned mostly about the pathophysiology of gallstones or cholelithiasis resulting in pancreatitis. However, we know that the second most common reason for acute pancreatitis could be the abuse or chronic abuse of alcohol. However, the cause or how chronic alcohol use causes acute pancreatitis is not clearly understood. Now, what the belief is that once the patient consumes an excess amount of alcohol, that would increase the production of digestive enzymes in the pancreas. And once those enzymes gets increased with all the inflammatory changes that we're seeing in chronic use of alcohol, that will then cause the backup of the excessive enzyme, and that will then lead to pancreatitis. Now remember what I said before. Although you might have a large number of patients that are abusing alcohol, only about 5 to 10% of those people might actually develop pancreatitis. So what the belief is, researchers believe that there are other factors that are contributing in addition to ETOH abuse, things like your environment. So maybe looking at the patient's diet, the fact that they're smoking, genetic, all other factors that could be contributing to the development or contributing to the cause of acute pancreatitis in patients that are chronic alcohol users. One other thing I want to add is just being mindful that the pathophysiological involvement of acute pancreatitis could be mild, where we're just seeing edema or swelling, interstitial pancreatitis, or you could have severe cases, like I mentioned before, what we call necrotizing pancreatitis. So that's where you're going to have your phospholipase A involved, you're going to start to have your elastase involved. So now you're seeing bleeding or hemorrhaging from the pancreas, you're seeing fat necrosis are occurring. So it really depends on the type of pancreatitis. So like I said before, it could be mild, where they're edematous, or you're seeing interstitial pancreatitis, or severe, that is referred to as necrotizing pancreatitis. So clinical manifestations of acute pancreatitis will obviously depend on whether it is milder cases, such as the edematous or interstitial pancreatitis, or they're more severe cases like necrotizing pancreatitis. Nonetheless, if a patient comes in with pancreatitis or acute pancreatitis, often what they can complain of is left upper quadrant abdominal pain, because obviously the pancreas is in the left upper quadrant. However, sometimes they can just complain of mid to epigastric pain that's then radiating into the back. So if you think about those referred pain, earlier from your earlier patho, then that would help you to understand. Nausea and vomiting, often GI symptoms. They might complain of generalized weakness. Depending on what's going on, the patient could be febrile. And like I said before, patient can experience shock secondary to that bleeding or the hemorrhage. And if you think back, what type of shock and all the different types of shock that we've covered, bleeding is blood loss, and it doesn't matter that it's not being lost to the external environment. Remember, we talked about absolute and relative blood loss. So if the patient is bleeding out from the vascular system, and now because they're bleeding out or they're hemorrhaging from the pancreas, that's now going to enter into the retroperitoneal cavity. So it is into third space. So they're losing intravascular volume, so that puts them into hypovolemic shock. Because of the retroperitoneal bleeding, there are two types of symptoms, or two kind of bruising that you will see, something called a Gray-Turner sign and a Cullen sign. With the Gray-Turner sign, the patient will have ecchymosis or bruising in the left flank or left costovertebral angle area. So flank, if you sit down and if you're sitting up right now and you put your hands on your waist, where your thumbs land in behind, that's considered a flank. Okay, on the side, come around, that's the CVA where your thumb is landing, costovertebral angle, where the palm of your hands are sitting, those are your flanks. So as you can see in the first picture, that's showing you ecchymosis or bruising in the left flank area. Now, also because of bleeding from the pancreas, it can end up into the peritoneal cavity, and what you start to see is some periumbilical ecchymosis. So bruising or ecchymosis around the periumbilical area. Now, the next diagram or the next slide, I found this again, courtesy of Googling these pictures. I really find this one helpful with my learning to remember where is the Gray-Turner and where is the Cullen sign. So if you put a C where the umbilical, like for periumbilical area, C for Cullen's, C for bruising around the periumbilical area, and the Turner sign is, you can sort of imagine a T being marked on the flank or on the side And that's the gray Turner sign that you're seeing in your patient. So this is all from the hemorrhaging. And if you think back, if I ask what's causing that hemorrhage to occur, you can then recall it's the elastase that got activated by trypsin, and the elastase then causing enzymatic breakdown of the elastic fibers of the blood vessels in the pancreas that will cause it to bleed into the peritoneal and retroperitoneal areas of the abdomen. So when we look at diagnostics, so how do we diagnose patients that are coming in with acute pancreatitis? Obviously, we will take a proper history from the patient. And so from the history, we're also, so let's say our patient comes in with left upper quadrant pain and or epigastric pain. Some things that we want to do is we want to do the amylase. We're going to do a lipase level. We're going to also run a calcium level because of how calcium is attached to the lipase. And so my question on the slide is, which diagnostic test for acute pancreatitis is most specific, amylase or lipase? And so the answer for this question is lipase. And the reason why is amylase can be produced by other areas. Now, I'll be very honest with you. Clinically, we run both. However, lipase is very much more specific when it comes to diagnosing if. So when we see an increase in a lipase level, it tells us that the patient have acute pancreatitis. Now, in your textbook, they talk about abdominal x-ray. Really and truly, those are abdominal x-ray is very limited test. So what you'll find more often being done for these patients is a sonography or abdominal ultrasound. And if everything else is good, the patient's creatinine level is good, they're not having renal impairment, then sometimes the physician would also order an abdominal CT if the sonography study or the ultrasound was limited. So diagnostic tests, obviously we're going to have the other basic diagnostic tests such as your blood count, you're going to do your leukocyte count. So you're going to do a full, complete blood count. But in addition, and electrolytes, obviously, so creatinine, BU, and all that stuff is going to be done. But tests that are specific, or diagnostic tests that are specific to diagnosing pancreatitis, are things like amylase, lipase, and because of the way they're bounded, we also want to check a calcium level. In addition to this, LFTs are always done, what we call our liver function tests. ALT, ALP is also usually ran while we're doing the amylase and lipase at the same time. So just to tie this up or to summarize this, these are all diagnostics that are done. So your amylase, your lipase, your calcium, LFTs or liver function tests. But if you were to think which one is most accurate for a diagnostic in diagnosing acute pancreatitis, it will be a lipase level. For diagnostic imaging, obviously an abdominal ultrasound is a better test to have than an abdominal x-ray, because an abdominal x-ray is a very limited test. Now, when we look at collaborative management or collaborative care, so if you have a patient with acute pancreatitis or admitted on your unit for acute pancreatitis, the care could vary, right? So like we said before, if they're milder cases, you might see some interventions being implemented or some orders being set by the physician, versus with severe cases, your orders might look a little bit different. Pain medication, so you want to give them analgesics. There are a little bit of debate about this. So certain analgesics, narcotics, such as if you think about things like if the hospital you're in are still giving Demerol, then it believes that this would further spasm the sphincter of Oddi, which is not beneficial to the patient. IV fluids is a must. Okay, so remember your patient, especially if they're bleeding from the pancreas or anything like that, we need to replace. So what we do is we're going to give them IV fluids to replace or to maintain that plasma volume. So usually we want to give them what we call aggressive hydration therapy. Electrolyte replacements, depending on what your lab diagnostic finds, then you're going to replace your electrolytes, whether it's sodium, potassium, calcium, you want to replace them accordingly. Bowel rest is very important. And so what we do is we put in a nasogastric tube, and that nasogastric tube is going to go to low to intermittent suctioning. And what we're trying to do there is we're trying to suppress. So by not having gastric content or by not giving the patient anything by mouth, what we're doing is we're suppressing the pancreas from secreting pancreatic enzymes. And so by doing that, you're putting the pancreas to rest, or we call this a bowel rest. So what you're doing is you're reducing vomiting and gastric distension, and you're preventing gastric acid contents from actually getting into the duodenum. Okay, so this is a big treatment or intervention, I should say, in the management of these patients. IV fluids for sure, because you need to do aggressive hydration therapy, but also the bowel rest is absolutely important during this time. If the patient is febrile and an infectious process believes to be going on, where you have, because of the inflammation and the necrotic pancreatic tissue, if you think about it, that will become a very good medium for bacterial growth. So antibiotics could be given once the patient is febrile, or it could be given prophylactically, knowing that these patients can then develop bacterial growth, and that will then not only put them into hypovolemic shock, but then septic shock. So the physician might choose to treat prophylactically with antibiotics. However, that is a controversial topic, if prophylactic antibiotic treatment is needed, or should the patient be closely monitored to see that if they will spike a fever and if that antibiotic therapy is actually needed or not. If the patient is hemorrhaging, secondary to the elastase, destroying the blood capillaries and causing bleeding into the retroperitoneal cavity, which you're going to see the Gray Turner sign and or the Collins sign, then blood products might be indicated, because if you're just going to be given the patient IV fluid, you're actually hemodiluting the blood, and so you might actually need RBCs or packed RBCs to be given to these patients so that they can maintain their RBC.